Well, Clay, thank you very much for having us, and it's truly an honor to be here at Clay's inaugural meeting and to see such a fantastic turnout. From what I'm hearing yesterday, it went very, very well, and I hope the meeting continues to do that. And Clay has been a mentor and friend to me for many years, and as to Omar, and we're really honored to be able to present this talk on pigmentary disorders. And when Clay first asked us to do this, we decided to sort of do this more on a clinical basis and show you case bases of some of the nuances in both inflammatory pigmentary issues that you may encounter on a daily basis in your practice, and some path nuances that Dr. Sangueza and I are going to point out together. So these are my conflicts, but nothing related to this presentation. So let's start a little bit with hyperpigmentation, and clinically, when you see many of these patients who come into your practice, you'll have many of them who come with a chief complaint of, I've got dark spots on my face and I want them lightened. Or many of them come in and say, oh, I've got acne, but it's really not acne. They're concerned about the small hyperpigmented macules throughout their face. And really, the pigmentary part of many dermatoses that we treat is really the most challenging. So when we think about pigmentary disorders, the most common thing we're going to see is, of course, localized hyperpigmentation, which really includes melasma and post-inflammatory pigmentary alteration. Many of us have biopsied things before, and our path diagnosis comes back PIPA, or forms of melasma, or dermal melanophages, and we'll talk a little bit more about that. But what we oftentimes don't talk about is what about the patient who comes in with diffuse hyperpigmentation, who comes in and thinks their face is getting darker, but they also have it on their neck and arms. And that should sort of alert you to more of systemic and other underlying causes, most specifically metabolic causes. So if you have someone who comes in with a diffuse darkening of their skin, think about some metabolic things, and you may want to check some lab serologies such as vitamin levels, thyroid, and even cortisol. Don't forget medications. All my patients who come to my practice with hyperpigmentation, or really any dermatosis for that matter, we do take a detailed drug history. There's been a number of cases of medications, which we're going to show you in just a moment, that can actually cause diffuse hyperpigmentation of the skin. And this is still out there with a number of new chemotherapeutic drugs, a number of new antihypertensives. We're seeing this more and more. Also, malignancy, don't forget that patients who have had a history of melanoma, if they come in saying that I feel like my skin is tanner and they have not had excessive sun exposure, they had melanoma several years ago, keep in mind to be on the lookout for recurrent melanoma or even metastatic disease. I have had 2 patients with metastatic melanoma who have come in presenting with hyperpigmentation of the skin. And lastly, this is somewhat rare, but keep in mind that autoimmune and infectious etiologies are also common, specifically HIV, which is most likely where you're going to see if someone comes in with somewhat hyperpigmented skin. So our first clinical case is this patient who presented to my practice. She is a 56-year-old African-American female who presented with a 12 to 13-month history of these non-paritic hyperpigmented patches. And if you can appreciate that the darkening of her skin is really throughout the entire face, somewhat sparing the mid-face though. If you notice, she's got almost this dark black hyperpigmented, almost dusky look that extending from the forehead all the way down to the lower neck. Also notice around the mouth, she has hyperpigmented patches there, which are almost confluent with the ears on the cheek. The nose is somewhat spared, as is the ears, and that's going to be important. Here's another picture of her, just a face on, and here I think you can appreciate more that the hyperpigmentation really stops at the upper chest, sort of at the junction of the upper neckline and that décolletage area. But she does have a diffuse darkening of the face, and this has been going on for a year. She denied any new products, no new fragrances. But when we did a detailed analysis of this patient's medical history, it turns out that this actually ended up being a photosensitive drug eruption from a hypochlorothiazide new blood pressure medicine she was on. And one thing I will mention is that many of the patients who come in with post-inflammatory pigmentary alteration due to medications, keep in mind that many of the new antihypertensives we're seeing are combination drugs, so it just doesn't have to be 25 or 50 milligrams of regular hydrochlorothiazide. This patient happened to be on a combo drug. So this started in mid-2012, and we diagnosed her as having a photosensitive drug eruption and subsequent post-inflammatory pigmentary alteration. So of course for this patient the concern was not really what was causing it, she just wanted her skin to be one tone. So it's important in many of these visits for us to guide our patients and let them know that we really do need to treat the underlying etiology in addition to offering treatment. When we think about PIH, the pathogenesis I think is important. Susan Taylor did this excellent study which really shows that on a microscopic level, PIH does have a true inflammatory component. And so because of this study and a few other studies out of the Indian literature, my patients who come in with PIH, I really do treat with high-potency topical steroids. When you do biopsy and look at path of PIH, and if you do immunohistochemistry, there are large levels of inflammatory leukotriene still present, even if this has been going on for many months. And topical steroids, therefore, do play a very important role in my practice in dealing with these patients. These are not just patients who you put on a bleaching agent. Of course, that is part of the armamentarium, but topical steroids are very important. We'll get into that a little bit more. Treatment options, as many of you know, are numerous. The first and foremost thing is to treat any of the underlying dermatosis. So you may have a patient who comes in, like the patient in the first case, but she may also have concomitant acne, seborrheic dermatitis, or other facial dermatoses if this happens to be on the face. And so it's important to make sure you treat that in addition to the pigmentation and guide those patients. Many people who you probably see come in have cystic acne, but also have PIH from different acne scars. And the goal of treating those patients is to let them know that if we don't treat your active lesions or your active breakouts, you're going to continue to get dark spots and it's going to be a vicious cycle. I do use topical retinoids very often. I prefer strong topical retinoids, especially tretinoin and tazarotene. I also use azelaic acid as a second-line treatment. This is off-label, but there's been a number of studies that have shown azelaic acid works very well in combination with retinoids and topical steroids for PIH and other forms of facial hyperpigmentation. Hydroquinone, of course, remains a mainstay, and there's been a number of studies that have been done that show the safety of hydroquinone is really unmatched and there is no excess carcinogenicity, which many people have thought in the past few years, but that has been refuted and it is a safe drug as long as you counsel your patients thoroughly. Chemical peels, newer cosmeceuticals, and of course reassurance, and we'll get a little bit more into that. I just wanted to touch briefly on chemical peels, and Dr. Sangueza is going to come up and do path in a minute. But chemical peels, I think, are very important, oftentimes underrated in many derm practices in the treatment of PIH. They're very inexpensive procedures, and patients actually do very, very well with these. I typically start with salicylic acid peels, typically 20 to 30%. I have these patients discontinue any retinoid 7 days prior to the peel, as many of you do. Some of us were talking at breakfast. But I do have them come in for the peels every 2 weeks, and I usually guide the patients that they'll need 4 to 5 sessions at minimum of a medium depth or light depth chemical peel before they're going to see any results. There's many studies that favor glycolic acid as being a superior peel. You may have seen that in some of the cosmetic literature. And I do glycolic as well in 30% concentration. However, I like sal acid because if you have a patient who also has acne, in addition to melasma or PIH, the sal acid kind of kicks in both at the same time. So I personally use more sal acid than I do glycolic because I tend to have patients who come in with multiple things going on, as many of us do. But you can use glycolic, and the studies do slightly favor that. Here's another example of a patient that we did in a study with Pearl Grimes, where you see on the left she's got really any patient who you'd see in your practice, dark pitted acne scars, hyperpigmented and hypopigmented atrophic macules, really on the lateral cheek, and many of those have obviously been excoriated over time. But this is after 5 sessions of monotherapy with salicylic acid 30% chemical peels and hydroquinone only. So you can see a very nice result at the end of 5 chemical peels only. As I mentioned, there's other things we can add, topical steroids, azelaic acid. It's a multifactorial treatment, I think, is the most important thing. Dr. Sangueza is going to do the path now.
Good morning, and thank you, Clay, for the invitation. The histology of post-inflammatory pigmentary alteration is very characteristic, and we see this many times, especially in African American patients, because it's easy to see these hyperpigmented lesions, and when they biopsy, what they see basically is sometimes you see a thin epidermis, and in the papillary dermis there are numerous melanophages. You can see this number of melanophages here. Here in the papillary dermis, sparse inflammatory infiltrates and bacterial changes. You see bacterial changes along the dermal junction here. Other thing that you may see is the presence of these keratotic keratinocytes, because many of these cases of post-inflammatory pigmentary alteration are secondary to interface dermatitis. It could be the end stage diseases like erythema multiforme sometimes, or lupus, or dermatomyositis. So those are the changes that you see. One of the things that's important to know, especially for dermatopathologists, to be aware that these things sometimes can be confused with melanocytic lesions. And I've seen a number of cases of post-inflammatory pigmentary alteration that they've been called melanomas in situ. So it's very important. I actually remember a case many years ago when I was treating with Dr. Ackerman. He called twice a melanoma in situ because the lesion looked like melanoma in situ. Those days we didn't have many special stains, and if you, we had, he didn't like to use. So it's important to be aware of that possibility that sometimes out of the context, these things they can be confused with a melanocytic lesion, especially with melanomas in situ. And you can see if you do special stains, sometimes melanine is going to show an increased number of melanocytes along the dermal junction. Some of them, they're not true melanocytes, are keratinocytes, they are pigmented. But anybody who is unaware of this fact is going to be making a diagnosis of melanoma in situ and leading to unnecessary treatment in patients. You can see this patient here with these lesions. One of these patients, I remember, ended up with a big scar because it was called melanoma in situ. So these all cases are post-inflammatory pigmentary alteration, and just for the people who do dermatopathology, be aware of that pitfall. And you know, melanine is not always a perfect marker to distinguish between this proliferation of melanocytes and true melanomas in situ.
Omar's case really highlights the fact that our clinical pathologic correlation is so important, even in something as common as PIH. So let's move on to our next case. This was a Hispanic female, 51-year-old Hispanic female who presented to my office, and this is one of those patients who you walk in the room as a new patient and you're kind of glad because you walk in and you know the diagnosis right away and you think it's going to be a very quick visit. But this is obviously a case of melasma in a prototypical Hispanic female. However, the reason I put this case is to give you a clinical clue on how you can really differentiate melasma from other forms of facial hyperpigmentation. And the point of this is to say that every patient who comes in with dark tan patches on their cheeks is not a melasma patient. I have seen many cases of patients come in who have been diagnosed with melasma, who actually do not have melasma and have other facial hyperpigmentation. And a clinical clue that you can use when you walk straight into the room is to look at the zygomatic arch. If you look at the place where I pointed that arrow, which is right at the zygomatic junction into the periorbital area, classic melasma does not cross that border. So if you have a patient with hyperpigmentation both on the cheeks, bilaterally, over the nasal bridge, nasal root, and you also have hyperpigmentation around the eyes that you're noticing, that patient most likely does not have melasma. Melasma really does respect the facial margins, especially along the zygoma, extending preauricularly, and then on the forehead. Of course, a number of treatment options for melasma patients, but I point this out as a clinical clue for you to be able to know when you walk in that, okay, this really doesn't look like melasma this patient has in the eyes, also has it in other parts of the face in atypical distribution. That should sort of tip you up to other causes of hyperpigmentation, either drug-induced, metabolic that we discussed, etc.
The histology of melasma is very non-specific. The only thing that we see is hyperpigmentation of the basal layer, and it's very difficult to find examples of melasma because nobody does biopsies of melasma. This is the only example I found in my files, and the only thing you see here is some of these patients may have a little bit of solar elastosis, and what you see is just hyperpigmentation of the basal layer. A few melanophages may be present in the papillary dermis and sparse inflammatory infiltrates. Actually, there's a lot of studies of melasma, but not in this country, but especially there are some studies coming from Puerto Rico where they try to find a specific histological features in melasma. But I think most of the findings in melasma are those of just mild hyperpigmentation of the basal layer, and sometimes a few melanophages and sparse inflammatory infiltrates in the papillary dermis.
So a number of risk factors, which many of us know. Of course, UV photoprotection is vital for these patients, given sunlight being a really high cause. But of course, hormonal issues such as pregnancy and oral contraceptives, thyroid dysfunction. I have seen a number of patients with melasma who are not on any OCPs, who are not on hormone replacement therapy, who have not been pregnant, who have a good history of doing good sun exposure, and really that tips me off to doing thyroid studies, and I've had a number of patients with hyperthyroidism actually present with classic melasma, so keep that in mind. And of course, never forget medications. And drug-induced melasma is somewhat different than drug-induced post-inflammatory pigmentary alteration, mainly on histology. And as Dr. Sangueza mentioned, if we know it's classic melasma, rarely do we ever biopsy it, but it is important to keep in mind that medications can cause this as well. Number of treatment options, but the most important one that I think most of us use is triple combination therapy, which includes uses of retinoids, topical steroids, as well as hydroquinone. This was a very nice study that was in the British Journal from Hong Kong, and it was a large cohort of patients who were randomized into a hydroquinone-only group versus a triple combination group and were treated for 8 weeks. And really, after assessing a number of treatment markers, including the melasma severity index called the MASI score, as more and more melasma studies are published, you will notice that there are these, similar to PASI scores, there's MASI scores and a number of different ways to grade this, especially on spectrophotometry. And what was found is that the patients in the triple combination group had a higher success than hydroquinone only. Many of us in this room obviously already do that, doing triple combo, but keep that in mind if you're not doing triple combination therapy, to do your best to accomplish that by adding a steroid and a retinoid. This was an example of a patient from that study. Again, classic melasma on the cheek. After 8 weeks of treatment with triple combination therapy, a very nice response. Azelaic acid I put in here as another option. This was a nice study out of Delhi. Rashmi Sarkar's group did a nice study on azelaic acid of use in melasma. And this was actually a patient study which was done with sequential therapy of using azelaic acid on one half of the face, 20% concentration, and on the other half of the face doing clobetasol for the first 8 weeks, followed by 20% azelaic acid cream. So if you think about doing clobetasol on the face for 8 weeks, many of us are a little bit gun shy and we may not necessarily do that. But the point of this study and many other studies is that class 1 steroids on the face, if safely used in short courses in sequential therapy, actually work very, very well. And the patients who did the clobetasol for 8 weeks prior to doing the azelaic acid did very, very well in improvement of their MASI score. And this study was interesting because these patients did not have retinoids or hydroquinone. So if you have a patient who's retinoid sensitive, who cannot tolerate retinoids, if you have someone who can't get hydroquinone or who has irritation or an irritant dermatitis, keep in mind that azelaic acid and topical steroids are another option you can use for your melasma patients. This was a picture of a patient from a study that Ariel Kovar in New York did on Q-switch ND-YAG laser for patients with melasma. And there's been a number of different controversies regarding laser in the treatment of facial hyperpigmentation, especially in skin of color. But there are a number of studies that show that laser treatments actually do very, very well if used in the right settings. In this study, this was a Q-switch ND-YAG laser study, 1064 nanometers, a low fluence fixed study at about 1.5 joules. So the key is to use a very low energy level and use a very fast laser. These patients were pre-treated with retinoids and hydroquinone prior to being enrolled in the study. They were discontinued 2 weeks prior to each laser treatment, and a total of 3 sessions were performed. But you can see that this is a very nice result for this young female. Again, if you notice, the melasma in this patient on the left picture is not crossing into the periorbital area. It's stopping at that zygomatic arch. So remember that clinical clue we talked about. All right, our next case. This was very interesting. This patient was actually referred to me by another dermatologist in town who had been really surprised with the diagnosis and the way this patient was handled. And if you notice, this patient has these very small guttate hypopigmented macules diffusely along the legs, somewhat even pinkish in color. There's a couple of scars centrally, and if you look here, you can see on the right-hand side, you can actually see scars. And what those scars were from a primary care physician doing liquid nitrogen, thinking this was idiopathic guttate hypomelanosis. And this patient had been misdiagnosed for several years. This patient subsequently had a biopsy done, and I'll show you a close-up picture. Here you can almost appreciate that these are not macules, that these are almost papular. They have a texture to them. And this was a very, very interesting case because this was an atypical presentation. I'm going to let Dr. Sangueza give us the diagnosis with the path.
Well, you can see here there is a lichenoid infiltrate composed mostly of lymphocytes and histiocytes. Difficult to see at this power dose, the composition, but believe me, that's what it is, and we're going to see in a little bit. Another feature that's important to see at low power, that there is some changes going also in the stratum corneum, and those You see here, there are extravasated red cells. There are areas of parakeratosis in the stratum corneum, and these infiltrates are composed of lymphocytes and histiocytes. Higher magnification, we see the number of extravasated red cells, these keratotic keratinocytes, and the presence of these inflammatory cells. Now, this is a case of pityriasis lichenoides, like pityriasis lichenoides. In this case, is in between pityriasis lichenoides acuta and chronica, and these are the characteristic findings. You know, lichenoid infiltrates, extravasated red cells, vacuolar changes, these keratotic keratinocytes, areas of parakeratosis in the stratum corneum. In the acute phase, in pityriasis lichenoides acuta, we see quite a few neutrophils. In the lesions of pityriasis lichenoides chronica, the neutrophils disappear, and you have only areas of parakeratosis. The other thing it's important to know is in late stages of pityriasis lichenoides chronica, sometimes we don't see these inflammatory infiltrates anymore, you know, because the lesions are late, and the only findings that we may see are those of parakeratosis and a few these keratotic keratinocytes. But this is a case of pityriasis lichenoides, in this case going to the chronic phase.
And going back to the clinical pictures just for a moment, on this image you can actually see the difference between what is an idiopathic guttate hypomelanotic macule right in the center and how that's different from the hypopigmented papules that are seen diffusely on the legs. So this was an atypical presentation of pityriasis lichenoides PLC. Next case, this was an Indian female. The next two cases are actually, you're probably going to think they're the same patient, but it's very interesting because they're not. And this was a 31-year-old Indian female who presented with this, what you can tell is a diffuse reticulated hyperpigmentation on the neck. It's extending up under the submental area and somewhat onto the upper chest, but you can see it's really localized just to the neck area. Dr. Sangueza is going to give us the path.
Well, this histology is very characteristic, you know, especially even for people that beginners in dermatopathology. What you see here is epidermal hyperplasia with areas of acanthosis, papillomatosis, hyperkeratosis, and hypergranulosis. This kind of V-shape hypergranulosis, that's very characteristic, and also the presence of lichenoid infiltrates. So you see these areas of hypergranulosis in the epidermis, and these inflammatory infiltrates, and irregular epidermal hyperplasia. It's possible to see some keratotic keratinocytes. You see a couple of these keratotic keratinocytes, also called CBAT bodies. So these are the changes, characteristic changes of lichen planus, and sometimes when this happens in dark skin patients, it's called lichen planus pigmentosum, because we can see quite a large number of melanophages. You see a few melanophages here in the bottom part of the screen. So again, this is a lichen planus pigmentosum.
So again, keep in mind the clinical image of the patient with her neck, and then if we look at this next Indian female, this happened to be a 33-year-old female who presented with again, reticulated hyperpigmentation of the neck, bilaterally extending this somewhat more onto the cheek area, and you can actually also see it extending down into the upper chest, but virtually identical. They could be the same patient actually, you know, wearing different clothing. And I biopsied actually both of these patients and got a different diagnosis, and there is a little bit of controversy in that, but I'd like Dr. Sangueza to talk about the nuances in this path.
Well, here the changes are not as dramatic as we saw in the previous biopsy. Here you see just the inflammatories are sparse. There are some vacuolar changes, inflammatory infiltrates, and the presence of melanophages. You see quite a few melanophages. It's very similar to the findings that we saw in post-inflammatory pigmentary alteration, and this disease is called erythema dyschromitus perstans. There's a lot of debate about what erythema dyschromitus perstans is, because this disease was described initially in Central America by Ramirez, and many people believe that these are just changes of post-inflammatory pigmentary alteration, and because you see the same findings, you see vacuolar changes, inflammatory infiltrates, and melanophages.
So 2 patients with reticulated hyperpigmentation on the neck with 2 separate diagnoses, and you can see that the biopsies of both of these patients do look different. There is a lot of controversy, as Dr. Sangueza said, on if lichen planus pigmentosus and erythema dyschromicum perstans are actually 2 separate entities. I can tell you that the Indian literature and the most number of patients who have had lichen planus pigmentosus and EDP are actually from the Indian dermatology literature. They do feel that these are 2 distinct entities. Personally, I think that erythema dyschromicum perstans is an end-stage process of lichen planus pigmentosus or another acute inflammatory response, and I think Dr. Sangueza just showed us that on path. But keep in mind that a patient who comes in with reticulated hyperpigmentation on the neck may have a form of lichen planus with an inflammatory component. You can have a good resolution with systemic and oral steroids trying to calm this down. All right, so switching gears for the last few minutes to hypopigmentation and depigmentation. This is an image of a patient who some of you may have seen in your practice. This happens to be from a study out of Australia, but you can see that this female has diffuse guttate hypopigmented macules diffusely over the body. These happen to be non-scaly. It may be somewhat hard to appreciate, but these are completely flat hypopigmented macules. Of course, the first thing that comes to everyone's mind when they see this is, could this be tinea versicolor? But if we look closely at the distribution, we know it's not. Here's an electron microscopy of this diagnosis. This happens to be a case of what's called progressive macular hypomelanosis. And some of you may have seen some recent JAD reports on this last year in October of 2013. PMH is a fairly newly diagnosed entity in the past 12 to 15 years. It was actually first described in the Dutch literature. And this is an electron microscopy of the DE junction and a number of melanocyte keratinocyte units in patients who have progressive macular hypomelanosis. And what you see in the upper left corner are the dense black granules and circular inclusions that are there, and those are actually the melanosomes in a normal skin EM. However, what you see in the lower right-hand corner is a large lack of those, and that's because this is thought to be an abnormality in the type 2 to 3 melanosome processing. So if we think back to our basic science of when we make melanin, the melanosomes are somewhat abnormal in this condition, which is what is leading to the hypopigmentation. If you were to actually do a biopsy for H&E, there would really be no histologic changes for this. So this happens to be an ultrastructural diagnosis. Here's a patient of mine who had this, and you can see that this looks like someone who has tinea versicolor on first glance, shown from this picture. On the left is a preclinical image. On the right is this patient at 1 month after using 10% benzoyl peroxide solution as a body wash. And the majority of these patients who come in have been treated many, many times for tinea versicolor. But if you look closely, these patients have no epidermal change. There's no scaling. You can't scrape them. And the distribution is much more widespread in males than it would be for tinea versicolor itself. If you notice that after a month of treatment, he's actually getting some of his normal color back, especially in the sacral area and in the lateral lower back. The reason you use benzoyl peroxide in many of these patients is PMH is thought to be due to P. acnes causing an abnormality in the melanosome function. That is controversial, but the etiology most likely tends to be due to Propionibacterium acnes, so benzoyl peroxide topically works well. So take-home point on this is if you have someone who you think has chronic tinea versicolor, you've treated multiple times, the pigmentation is not improving, think progressive macular hypomelanosis, try benzoyl peroxide, and you'll probably get some improvement. This is an image of a patient who actually has vitiligo. And if you look in the upper left hand, this is a patient who has really progressive vitiligo disease. And in the lower right hand, I wanted to show you this image, which is 3 weeks after using 20% monobenzyl ether of hydroquinone. And many therapies in vitiligo, of course, our goal is to try to bring the pigment back. But what do you do when you have a patient with greater than 50% body surface area whose pigmentation is not coming back? And one of the things that I think is under-discussed in dermatology is actually using depigmentation as a therapy for many patients. That's a whole talk in itself, but what I wanted to do was at least point that out, that you can easily depigment patients if done the right way. And typically the way to do this is using a topical 20 or 40% monobenzone cream, which many compounding pharmacies can actually make. What I typically do when I start this is have patients use the monobenzyl cream on one area, usually the arm, twice a day, morning and evening, for 3 to 4 weeks. And the main reason to do that is to ensure they're not having an allergic or irritant contact dermatitis. After those 3 to 4 weeks and their body is sensitized, you can actually have them apply the depigmenting cream to all areas where they currently have their normal skin and advise them that the depigmenting process takes about 6 to 9 months. In my practice, I have about 34 patients that I've depigmented total, and most of them have done very, very well. except for, here's an example of someone who did not do very well. This was a 70-year-old Hispanic male who, as you can see, his color at this point, his uniform color is the sort of lightish pink, whitish skin on his face. But what you notice are these really dark, dark patches around the forehead and around the cheek. You can also see that he's getting a lot of these hyperpigmented patches in the ear. So in some ways, you would look at this picture and think, oh, maybe this is someone on narrowband UVB who's actually getting repigmentation and getting that perifollicular guttate repigmentation of their vitiliginous skin. Actually, this is not. What this is someone who I depigmented who did not use excellent photoprotection constantly, which includes physical blocker sunscreens, wide brim hats, making sure they limit sun exposure, which is a lifelong challenge for patients who you do depigment, and subsequently had what is known as paradoxical hyperpigmentation. So it's important whenever you do these procedures to realize the side effects and counsel these patients extensively that they do need lifelong photoprotection once they are one uniform color, because if not, they can actually get a paradoxical hyperpigmentation. This can then be treated very easily. My treatment of choice actually for this is liquid nitrogen. I actually do liquid nitrogen to the areas of the dark pigment that have come back, and it works very, very well. Many vitiligo people like Pearl Grimes and Jim Nordland actually do dermabrasion. They find that works well. Liquid nitrogen is just very easy to do, and it works easily.
Believe it or not, we get quite a few biopsies for patients from vitiligo. I think sometimes clinicians want to establish the diagnosis, especially in Hispanics and Black American, African American patients, because we are going to talk a little bit about other diseases that can simulate vitiligo. But the histology of vitiligo is very non-specific. You see basically a normal skin with an absence of melanocytes in the epidermis. You see here, there's melanocytes, or those cells that they have cytoplasm, maculated cytoplasm, can have a little bit of melanin in the inside. Here you see there's none of that. There may be a few melanocytes here and there, but you see a virtual absence of melanocytes. But this diagnosis is not easy to make on hematoxylin and eosine stains light, so it's important sometimes to do special stains, like in this stains, a melanin is a stain that highlights the presence of melanocytes, and you can see there's virtually absence of melanocytes. This is a Fontana Mason, that's the stain that we used to do in the past, and you can see here are two areas, one area with normal numbers of melanocytes and another area where there is absence of melanocytes. So that's how we make the diagnosis of vitiligo.
So just to recap some clinical things, it's important, as we talked about, to do a detailed medication history, family history, and one thing that I do want to mention is many of your patients who come in with pigmentary abnormalities, don't be afraid to do patch testing. There's been a number of patients who I've seen who have actually had an allergic contact dermatitis and subsequent post-inflammatory hyperpigmentation, so doing patch testing in the office can oftentimes be beneficial when you're suspicious. Serial photography, I think, is very, very important, using a dark background, and especially taking pre-treatment photographs. Have your nurse or medical assistant take some pictures of these patients, especially if you are going to do chemical peels or prescribe some of these compounding agents. Many of these patients are oftentimes discouraged and have seen multiple other doctors before and been told there's no treatment or there's no hope. If you've done one round of hydroquinone and it doesn't lighten, then that's it. There's no other options. And so oftentimes the mentality is for these patients that, oh, nothing's working, when in reality they are doing better, and the photography can really help you. Empathy, as always, will work very, very well for these patients. Again, they're frustrated. They want your help to cosmetically improve their skin. And lastly, as Dr. Sangueza mentioned, don't be afraid to do a biopsy. I oftentimes do 2mm punch biopsies, that clay reads that are from the face. They heal very well if taken from the zygomatic or preauricular area. Those areas are very forgiving. And a biopsy can be actually very helpful in your diagnosis and subsequent counseling and treatment plan. Triple combination therapy, as we talked about, adding on chemical peels with sal acid for acne, dermabrasion if needed, and of course photoprotection.
Because we are running out of time, we are going to skip this case, but let me just go to the last case, because I want to show you this is that it's coming more and more. We see more often, and this is the so-called hypopigmented mycosis fungoides, and in North Carolina we see quite a few African American patients, and they can present with these areas of the pigmentation that can be quite large, involve large areas of the skin, or can be just small areas in multiple parts of the body. Usually are children and young adults, the ones that they have this type of lesions. And when we do a biopsy, we see the characteristic changes of mycosis fungoides, and sometimes it's not a good clinical pathological correlation because most of these patients, the clinical diagnosis is vitiligo or hypomelanosis, or many, even vitiligo can be entered in the differential diagnosis. And you see here that there is increased number of lymphocytes, and some of the lymphocytes are present in the epidermis forming collections. Here you see these lymphocytes are a little bit atypical, and we usually do special stains in order to confirm this diagnosis. We do different T-cell markers, CD3, you can see there's an increased number of CD3 cells. CD4 is characteristically decreased. That's one of the characteristic features of this hypopigmented mycosis fungoides. Regular mycosis fungoides has increased number of CD4 cells. In hypopigmented mycosis fungoides, there is a reverse ratio. There's more CD8 to CD4 cells. And another feature that we see is the decreased number of CD7 cells that we see in all types of mycosis fungoides. So this is just hypopigmented mycosis fungoides. Be aware of this disease because we are seeing more and more often this type of mycosis fungoides. Thank you.
Thank you very much for your attention. Hopefully this was helpful and has some good clinical path correlation. Thanks for your attention.